Thank you. I'm Shashwat Desai. I'm from the University of Pittsburgh, and I'm going to talk about the prevalence of clinical core mismatch in LVO strokes. To understand mismatch, we'll go into stroke pathophysiology. So in the event of an LVO, two types of abnormal brain tissue can exist. One is the core, which is an irreversibly infarcted brain tissue, and surrounding that is the penumbra, which is reversibly dysfunctional, but can be salvaged if the vessel is opened up. So any patient with a small core and a large penumbra is said to have a mismatch. We started to realize that there are several stroke phenotypes, but two distinct forms exist, slow progressors and fast progressors. And slow progressors are those LVO strokes which have a small core despite long-standing occlusion that is beyond 6 hours. And fast progressors are those LVO strokes where within a few hours, the core becomes very big. We know that 2 million neurons are lost per minute during an LVO stroke, but this is an average, and the range actually is pretty large, ranging from less than 35,000 neurons per minute to more than 27 million neurons per minute. So let's assume this is the universe of all LVO strokes. The ones in yellow are the ones who come in before 6 hours. The ones in orange or brown are ones who come beyond 6 hours. Our current understanding is that LVO strokes in the early window, a majority of them have mismatch. But in the late window, we don't know how many have a mismatch. We assume it is lower than the earlier window. And this difference dictates how we select patients for thrombectomy. In the early window, we are okay with a stroke scale score and a CT. But in late window, we want to know the core size and the volume of the mismatch. Hence, we go for a CT perfusion or MRI. This has implications. Let's assume two patients. Patient A is a 79-year-old female with stroke scale score 15. Her aspects is good, right ICA occlusion. Similarly, patient B is 82 years old, stroke scale score 15, and aspects is good, 9, left ICA occlusion. The only difference is the first patient came in at 4 hours, and the second came in at 16 hours. Both these patients require thrombectomy. For the first patient, you can just go and offer them thrombectomy. For the second one, guidelines dictate that you need to do a CTP or an MRI. So the problem with this paradigm is that for late window patients beyond 6 hours, you need to undergo some kind of extra imaging. And advanced imaging has its limitations. It is time consuming, time is brain, we don't want to waste time. It is expensive, it is not there everywhere. In resource limited settings, you cannot always get a CTP or MRI. It requires costly software to process those images, and it leads to over-selection. And this has been proved because the number required to treat in the late window trials was far lower than the number required to treat in the early window trials. So the question is CT imaging adequate in the late window? This was a great study from the German stroke group where they applied early window paradigm to late window patients. So they treated Hermes-like patients in early window and Hermes-like patients in late window. So they just used NIH 6 or more and aspect 6 or more. What they found was that outcomes are exactly the same. There is no difference. So to answer this question, we wanted to characterize the impact of time and aspects on the prevalence of DAWN trial-defined clinical core mismatch. The DAWN trial defined mismatch in a way that if you have severe stroke symptoms and a small stroke volume, that's a mismatch. So stroke scale score of 10 or more and core volume less than 30, mismatch. Stroke scale score of 20 or more and core less than 50, that's a mismatch. And we hypothesized that the prevalence of DAWN clinical core mismatch remains constant over time when you control for aspect score. So we took consecutive patients, every LVO coming to the CSE, treated and untreated, who underwent two kinds of imaging, CT head and CTP or MRI. Both of these were processed using automated softwares. Brainomics was used for CT head, we got E-aspects, and Rapid was used for CTP, we got the core volume. Our LVO population was pretty standard. Mean age was 70, NIS score median was 17, 35% patients had a core of more than 50 ml, and only half of them got thrombectomy. So we had untreated patients as well. What we found was this. If we break up the 24-hour window into 3-hour intervals, we find that gradually there is a decay in the prevalence of dawn-defined clinical core mismatch. But if you observe closely, up to 9 hours, it remains in the range of 52 to 65%, after which it drops to 40 to 45%. And at 18 hours, it really drops down to 25%. On an average, it decays at 1.8% per hour. But the real question is, when we control for aspects, what is the impact of time on mismatch? Across 24 hours, on an average, patients with aspects of 9 to 10, 77% of them had a dawn-defined mismatch. In aspects 6 to 8, it dropped down to 65%. In low aspects, less than 6, it was very low. Only 13% had a dawn mismatch. On an average, for every aspects point, mismatch declined by 5.5% for every aspects point. But interestingly, when we graph this out by time, we find that for individual aspects groups, the prevalence of dawn mismatch does not decay over time, at least not up to 24 hours. After that, it may. So in summary, dawn mismatch declines very gradually over time. But when we control for aspects, it does not decay. In patients who meet Hermes criteria, that is aspect 6 or more, the prevalence of mismatch across 24 hours is 72%. In the early window, it is 65%, and in the late window, it is 78%. The p-value is not significant. And in aspects less than 6, that is bad aspects, the prevalence of mismatch is very low. It's in the range of 15 to 20%. So in conclusion, CT aspects can detect clinical core mismatch irrespective of time window. Aspects more than equal to 6 is adequate for late window patient selection for thrombectomy. And the utility of advanced imaging in low aspects needs to be investigated further. Thank you.